now it's time. So we have to start everything, our scheduled activities on time. So accordingly, participants have now joined us, and I hope some others will join us along our journey of presenting our agenda items and continuing our activities. So the first activity is acknowledgement of the country. Therefore, I would like to acknowledge the Aboriginal people as the traditional owners and custodians of the land on which we are hosting this webinar today. I pay my respects to the elders, past, present, and future, and recognize the continuing connection and contribution to this land. I would like to extend that my respect to Aboriginal people if they are in this meeting today. With this acknowledgement, what I'm going to do is there is a housekeeping rules for us. These are, number one, please drop your questions. If you have any questions, you are kindly asked to drop in the chat box, in the Zoom chat box. Secondly, please keep yourself mute while speakers are conducting their speech, and you can ask permission or can raise your hands through the tools that are available on the Zoom applications. So I've already asked you which city you are now joining us from. Therefore, these are my few housekeeping rules. With this, I would like to introduce our today's or tonight's, I can say, because this webinar is broadcast across the globe, and I should say today or tonight, it doesn't matter. So we have 4 experts because of their education, their experience, their research, who are delivering a talk. Delivering a talk on eye health. Today is World Sight Day. Therefore, you will listen a lot more on this topic. I don't want to unpack everything. I leave that to experts. So we begin with Julie Tyers, who is OAM, and she's from Eyes for Africa, and she will talk on what we do and how we can do more. Following Julie, Dr. Deus Bigirimana, who is the president of Brunswick Lions Club. He will talk on lived experience-led initiative to raise awareness of glaucoma, the case of Burundi Glaucoma Association. After Dr. Deus, Dr. Simon Skalicky, Associate Professor of Melbourne University, will talk on enhancing diagnosis and monitoring of glaucoma in Africa through ionic visual field test. Then finally, Dr. Geoff, who is also OAM, will talk on affordable procurement of quality equipment and disposable. So with that, before we start the talk, I would like to remind our participants that you will find in the chat box the emails of all the speakers. And if you have any questions for further communication, you feel free to send to them. But if you have any questions, we have time for discussion and Q&A. Therefore, let me introduce Julie Tyers a bit more. Julie Tyers is an ophthalmic nurse with over 40 years experience. She founded Eyes for Africa, EFA, in 2007 after seeing the need for free sight restoring cataract surgery while traveling in Ethiopia. Her charity is run solely by volunteers, and funding comes from private and public donors. Julie was presented with the Order of Australian Medal for her contribution to international eye care in 2018 by the Australian government. Following the 2023 campaign with the Oromia region in Ethiopia, EFA is now working towards sustainability by introducing a primary eye care clinic at the Meki Hospital, situated in a village 3-hour drive from Addis Ababa, the capital of Ethiopia. Julie will now present her talk entitled What We Do and How We Can Do More. Julie, now as for you.
Thank you, Jonas. My name is Julie Tyers, and I am the founder of Eyes for Africa in 2007.
Just a friendly reminder, if everyone could please kindly mute themselves.
So I founded, this charity is designed to restore sight to people living in the remote and rural places of Ethiopia. I founded it when I saw the need while travelling through Ethiopia. Through this presentation, I'm going to take you on a journey of the campaign that we did in this year in January. So it is what we do and how we can do more, I will explain. Ethiopia has a population of over 122 million people. There's only 130 ophthalmologists, and they work mainly in the main city, the capital, Addis Ababa. It's estimated there are 800,000 people that are needlessly blind and preventable blindness because they have cataracts. For those that don't know what a cataract is, this is a cross-section of the eye. The white part is the lens, and you don't normally see the lens, but you see through it. When that becomes opaque, cloudy from aging or trauma, some drugs, and genetic, you can't see what you are looking at because the lens is in the way. It's cloudy and brown. So we take that out, as we do in Australia, and we put a new clear lens in. Can you imagine living in a country like this when you were blind, walking down a street with all those obstacles in the way? If you didn't follow something, that you'd probably go down the ditch or get run over by a horse and buggy and a Bajaj. So how do we get all our patients in? Wide, wonderful places that these people live, far away from modern medicine or roads. So we discussed with the Oromia Health Bureau on this campaign, and they sent out a man to let the village people know when we would be arriving and when we would be leaving. The message goes out to the markets, to the churches, and to the radio announcement. So we're always very excited when we do arrive at our destination that there are many patients waiting for our service. I'd like to introduce now Said Idris. This is one of our legacy leaving. Said was an ophthalmic nurse in 2007. That's when I met him. He was a high-achieving nurse that was recommended to be part of the cataract surgeon program at the time in 2011. He passed with flying colours and now works for Orbis International Eye Care in Jinka, and he comes with us on our campaigns. He's now reviewing the patients that have been triaged to make sure that they are suitable for cataract surgery. So once that's been organised, the patients are interviewed, the visual acuity is taken, their pressures are checked for glaucoma, they have a biometry to measure the length of the eyeball and the curvature of the cornea. They have the explanation in the translator, with the translator, and because we're in the Oromia region, they speak Oromia Fa. So sometimes we need 2 translators because the national language is Amharic. So we have all those details down in paper, and the explanation is given, and the patient then needs to sign the consent form. Mostly they are illiterate, so we use an ink pad and their thumbprint, and if they can sign, we take a signature. So the patients are all brought in, and some of the outer gowns are taken off, and we put our nice clean gowns on with a shower cap, and we put booties over their feet or their shoes. We're very lucky. I'd like to introduce Mr. Watt, who was our cleaner. She would wash our disposable gowns and booties for us. But the most important thing is, some of you might know, that all nurses love a coffee break. Every morning we'd arrive at the hospital, and Mr. Watt would have roasted the green coffee beans until they were brown and wafted it all through the whole complex. She would then pound it with the mortar and pestle, and when it was into a powder, it would go into the coffee pot, and that's when we would enjoy our morning tea. Very traditional, the coffee ceremony. So when the tea break's over, the patient is ready. There's a number, an Eyes for Africa number above the eye to be operated on. Their names are difficult for us. We have the lens chosen, the consent signed. Then the ophthalmic nurse in Chamois would give a retrobulbar block of lignocaine 2%. The patients don't fast and they don't have cannulas. So the lignocaine is put under the eyeball and goes towards the 4 muscles that meet at the back, so that the muscles don't move and the patient doesn't feel any pain. It's an example of cataracts. They've had these cataracts for a long time. We did do some bilaterals on the same day and others on different days, depending where they lived. And this young girl has a traumatic cataract. So the type of surgery that's done in Ethiopia and in Africa is very different to what we do in Australia. It's a very manual procedure. There's a 6 millimetre wound instead of 2 millimetres. The lens is extracted in one piece. The lens is put back in the bag. We use Ringer's solution and Simcoe. So it's all very basic. We use single-use only blades, and all our sterilising goes into the pressure cooker. So it will survive the rigours of the Ethiopian roads. So this is the 2 theatres we had, 2 surgeons we had operating in Meki Hospital. We have self-funded volunteers, plus we paid the local staff, the ophthalmologist, our cataract surgeon, and an ophthalmic nurse as a scrub nurse. So when the patients had their operation, they have a patch on their eye. They're instructed to leave it on till the next day. We introduce them back to their family and tell them to come back in the morning, leave the patches on. We give them paracetamol when they leave, and 2 paracetamol to have overnight if they need it. Some patients don't have anywhere to go. They've come a long way, they don't have family, and they don't have money. So we make sure everyone is fed. We give them the local injera, which is a fermented milk with a sorghum or teff, and shiro, which is a ground chickpea paste, which is nice now and then to eat. The other photo is the cafeteria at Meki Hospital, and this is our lovely cafeteria lady cooking a meal for the local staff. So the patients come back, and we're all very keen because we see some very blind patients who've been blind for a long time. We recognise them, and the patches come off. The surgeons take the patches off. They check their visual acuity, wash the eye with diluted betadine, and instructions are given about how to put the drops in. We ask the relatives to put the drops in so we can see they know how to do it. The compliance rate is very poor. The infection rate is nil. We give them subconj, DEXA and Genta for those that have that question at the end of the surgery. We give them donated beanies that someone has knitted and sunglasses, and they're on their way. On this trip, we were very fortunate to have Barry. Barry works with the guide dogs and has for many years. He's an Irish man that lives in the UK, and he was very keen to bring over some white canes. weren't sure if this was going to be a success or not, but you can see the blind person is feeling his way around the white cane. And Barry spent 2 or 3 days with each person that he handpicked so that they could navigate the area and understand the use of the white cane. He also encouraged us to have a go. We had walked up this corridor every day, and you would think that you would remember, but when you are blind and using a white cane, it was quite a horrible experience. So Eyes for Africa has transformed many lives from having to be like this to this. These are just a few of the 4,000 people whose sights we have restored, thanking the donors and the self-funded volunteers since 2007. But we know we can do more now. We will be opening an eye clinic at Meki Hospital to provide primary eye care to 56,000 people that have no access to eye care. This is the Meki Hospital. It stood out to me as well loved, and people had ownership of where they worked. The gardens were attended to, they were watered, pruned, replanted. The floors were always clean every day. There was no bad smells through the place. There was no old furniture stuck between buildings, and the operating theatre was as sparkling as you could imagine. So who do we need to make this happen? So we need an experienced ophthalmic nurse on a full-time 6-month contract. We'll try the 6 months just to see where we're going wrong and if this is going to work. The cost of this is 250 Australian dollars per month. We also need some equipment. We need a slit lamp, a pressure-taking probe, we need medications, dilating drops, anaesthetic. We need a few instruments and a small sterilizer, furniture and little bits and pieces, all very doable. And why do we need this to happen? Why does Meki area need an eye clinic? When we were there in Meki, this little boy turned up with his dad and has a lesion on his eye. We employed Banch, a Malak from Gonda, as an optometrist, and she came with us on our campaign. And she was able to tell Dad that this boy has a vitamin A deficiency. I've never seen it before. So he was told he has to eat certain vegetables, and Banch gave him treatment, and he reassured the dad that he would be all right and that the lesion would stay, but it's not going to change into anything awful. How reassuring is that? An eye clinic that can tell you those things. This little girl came with conjunctivitis. Her mother was quite worried. I met her and actually walked in with her into the hospital. Banch gave some nice soothing drops and some dexamethasone, gave her some sunglasses and told the mum, we're going to be here for 2 weeks. So if you have any more problem, come back. That's why we need a clinic. We need someone to refer, to reassure, to treat people. We also, on this campaign, had reading glasses. And that was very successful because people there read their Bibles, they do craft work, and we all know as we get older, we need glasses. It's out of their reach. There's nowhere to get them. In comparison, Shamshemini, our second 2-week campaign, this young man, little boy, came in with his dad. They travelled 3 days to Shamshemini, where there is an ophthalmologist and 2 very experienced ophthalmic nurses. He'd been kicked in the eye by a donkey. He'd already got a cataract, he had uveitis and raised intraocular pressure. He was treated, we paid for his medication, and he may have had a cataract surgery done already. There's another little boy there with a lump on the side of his eye that can't be treated in a rural hospital, but at least he can be referred. So who do I need to help me with all this? This is Dr. Dredgy. He's the head of the Oromia Health Bureau. And Dr. Hilpo's in the other slide. He's the manager of Meki Hospital, very keen to have us there. I've also got the flamboyant Dr. Agrawal. He allows me to store my equipment in his hospital and has been very proactive in organising equipment. And Mohammed Alimo is Ethiopian. He lives in Melbourne now, He studied at the university and worked with the Oromia Health Bureau. He knows the nuances of a different culture and how to navigate and make things happen. So as a vision for the future and making Africa a better place for blind people, we have a vision for the future towards advancing eye health in Africa. We will embrace the use of the ionic technology and the laser to manage glaucoma patients at Meki Hospital in the future. We can't save the world, but we can make a difference. I hope you've enjoyed the journey. Back to you, Jonas.
Thank you so much, Julie. Thank you so much. So if anyone has, I haven't yet received any question in the chat box, but if there are questions, then we have question and answer as well as discussion session. So I have forgotten to mention two things. Number one, it's a long day and I haven't even introduced myself. I am Jonas Dare. I am secretary of Brunswick Lions Club. So this is something that I shouldn't have skipped. The second point is we are recording this session for further educational purpose. Therefore, please, if you feel free, keep your beautiful and smiling, attentive faces on. If you don't feel comfortable, please feel free to turn off your video. Having said that, my second speaker is Dr. Deus Bigirimana, who is an ophthalmologist by training, a researcher, Brunswick Lions Club president, founder of Burundi Glaucoma Association, and he has a long list of titles. I can't finish all them. I don't have enough time to introduce Deus. Therefore, I hand over the session to Deus. You have 10 minutes.
Okay, thank you so much, Jonas, for this introduction. And thank you so much for all the people who attend that webinar and all the speakers who made the time to come and talk about the challenges that Africa ophthalmology is facing and the potential solution that we have. So I'm going just to present on behalf of people who are in Burundi, who have contributed to building a patient-led organization that raise awareness and advocate for available glaucoma care in Burundi. So for those who don't know where Burundi is, it is a small country with a rich culture and a good people. Situated in the Great Lake of Africa, we swing between Francophone and Anglophone. So that is why even my accent is between French and English. So I'm sorry for those who will find my accent very strong. The country is currently recovering from decades of political insecurity, which has really affected both the economic and the health systems. As glaucoma is defined as a silent thief of sight, and the #1 cause of preventable blindness worldwide, and it is really prevalent in people of African ancestry. It's also known that glaucoma in African population occurs earlier and progress quickly like Usain Bolt run. So in this presentation, I will just try to talk about the role of individuals who are lived experience, who have glaucoma, in raising awareness and making things changes. Here are some barriers that I have identified, the barriers to glaucoma care in my home country. First thing, as you can see in this slide, is the first thing is the lack of awareness of glaucoma. The second one is the lack of human resources. The other one is the lack of equipment, a poor health system, and expensive medications, especially for glaucoma. I used to look after patients who were diagnosed with a glaucoma. One told me, I stopped medication because I felt my vision has improved, while another person stopped because he has a headache, blaming his drops. It is really difficult to translate glaucoma in our local languages. And some of the elderly patients deny glaucoma disease and they refuse drops or surgery, arguing that it's because of age and that glasses can help them prevent glaucoma, treat glaucoma. With the majority of the population in our home country or in many countries of Africa, it is very difficult to hand over them a written information that we are able to use in Australia. There are less than 2 ophthalmologists per 1 million people in Burundi, and 80% of them are based in the capital city, where 6% of the population live. And there are 38% who practice surgery, and the 14% are appointed in rural areas. What do we have as equipment in Burundi? Really, we don't have too much. We have only one SLT machine. This is from information from my colleagues who are currently working there. We have 4 visual field machines that are working in the whole country for 12 million people. We have one optic coherence tomography, which is an eye test that we use to test especially glaucoma and the other disease. We conducted a survey among our colleagues, asking them how they use and follow up glaucoma. There were 1 in 3 clinics that have a tonometer, which is a basic equipment that they use to measure the intraocular pressure. 10% of our practitioners said, we have confirmed that they measure pressure of the pressure of the eye routinely. And 85% of the patients undergoing glaucoma surgery, they live in a rural area and they don't have a healthcare insurance, which means they can't really afford ongoing follow-up for glaucoma. This is an example of one of the patients I was following up in Burundi who has really started running a project. This is one of his testimony. He has suggested that his story started in 2000 when he has some fatigue. He was prescribed some drops, but he stops because he wasn't really sure that he was something that was treatable, but that he needs long-term follow-up. I met him in 2019, in 2018. His glaucoma was really advanced, and I was able to perform a visual field that confirmed that he has advanced the disease. I have prescribed drops and discussed about the surgery, but he didn't come back. It's when I was in Australia that he contacted me, telling me that he cannot drive, he cannot work on the stair, he cannot not do nothing, and that he can't even use his computer because he was missing the cursor of his computer, of his mouse. So I told him, unfortunately, I'm not here, but I can refer you to one of my colleagues. Then his pressure was really elevated, and he was now booked for surgery, but he couldn't afford because his salary was not enough really to pay surgery. So we tried to contact a friend just to contribute, and then we paid for his surgery, and he was very happy. He said, I'm going to work for other patients because what happened to me, I don't want that to happen again to other people. That is how we really created the Burundi Glaucoma Association. So we have conducted a lot of activities, and our vision is we don't want our country really, we want our country to have equipment for patients, essential equipment. And our mission is to increase awareness of glaucoma and advocate for affordable eye care. This photo here, you will see in my right hand, this is the patient, and in the left, it is the president of the Burundi Society of Ophthalmology. And in the middle, there is a representative of the Ministry of Health. And conducting that conference, it demonstrated that together we can make a change. Here, in the left, you have the Dr. Buldengeri Patrick, who is the president of Ophthalmology Society, and the patient. They conducted a joint awareness creation initiative, which has really been very successful last year. On this one, we have an ophthalmologist, and another one, a friend of a patient. He's not a patient, but he said, I'm going to come and talk about. He has the skills in project management, in project evaluation and the monitoring. And he said, I'm going also just to contribute because glaucoma can affect anyone. So I would like to provide some take-home message. Glaucoma is everyone's business, and lack of awareness and the poor health system are the common cause of late presentation to care and the poor adherence to follow-up. Partnership between patient, eye practitioner should be promoted across Africa, as it plays an important role in raising awareness of glaucoma. Individuals with lived experience, church, mosque, radio, may increase awareness of this silent disease. And to conclude, please love your eyes at work, and thank you so much for making your time. I'm available for any question or any comment that may arise from that presentation. Thank you, Nas.
Thank you so much, Deus. There is one comment, but I think I have to keep it for the Q&A. And there are two comments for Julie. So I keep both these three comments and questions to the last session. So the next speaker is Professor Simon. Simon Skalicky is an Australian glaucoma subspecialist, ophthalmologist with a passion for using digital technology to improve glaucoma service and patients' experiences. He is an associate professor at the University of Melbourne Centre for Eye Research, Australia, where he teaches medical students, ophthalmology trainees, and glaucoma fellows. Professor Skalicky serves on the Australia and New Zealand Glaucoma Society executive and the editorial board of the Journal of Glaucoma. He is the immediate past president of Glaucoma Australia and is actively involved in the World Glaucoma Association. Simon is both a clinician and a glaucoma researcher with over 50 publications, a strong advocate for patients. His research background includes the impact of glaucoma on patients' quality of life and, more recently, the benefits of online visual field testing through personal devices. In 2019, he founded Ionic, supported by Microsoft, to provide online visual field testing on any computer or tablet. Simon will now present his talk on online visual field testing, innovation and opportunity in Africa, or enhancing diagnosis and monitoring of glaucoma in Africa through Ionic visual field test. So now the platform is yours, Simon.
Thank you, Jonas, and thank you to everyone who's contributed to this webinar. It's been so wonderful to share it, and really this has been a journey for me, and it certainly has been a team effort. And it's just a privilege to work with so many wonderful people, turning this vision into something that's actually going to make a difference. So as Jonas said, our vision is to do the job of visual field testing, but not using machines, using software that'll work on anyone's device. So we're replacing dedicated hardware with software that's versatile. These are my declarations. So before I talk about the technology that we've been working on, I want to just take a step back and talk about glaucoma and what glaucoma is. So glaucoma is a disease of the optic nerve. Here is the optic nerve. You can see it at the back of the eye. It connects the eye to the brain. This is the view on the side, and here's the view face on. And so without it, we can't see. And what happens in glaucoma is that pressure in the eye, or think about the eye getting more and more firm, that pressure damages this nerve. The nerve is very sensitive to pressure, and that can lead to changes to the nerve that you can see here, and also loss of peripheral vision. It requires pressure tests for people to check their eye pressure, and also a visual field test to see what sort of damage has occurred and how bad the glaucoma is. The issue about glaucoma is people are unaware of it until it's very advanced. So often glaucoma can be occurring and people don't know. And that's why it's important, if we want to save sight, to pick it up as early as possible. Once we detect glaucoma, there are things we can do to lower the eye pressure to stop it getting worse, such as eye drops or the SLT laser that Deus and Julie mentioned, or surgery. But sadly, there's many people in the world with glaucoma, and you can see that a lot of people are undiagnosed. So the numbers are 80 million people in the world with glaucoma. In the developed world, in rich nations, 50% are undiagnosed. So that's a very high number, but that number reaches 90% in some of the developing world and some of the more poorer places that we've been talking about. So, and I'll talk about why that disparity in a moment, but first I want to focus on the visual field test and why it's so important in glaucoma. So as I said, people are often unaware of vision loss from glaucoma until it's very advanced. That's why we need to screen for it. Glaucoma tends to affect our peripheral vision before it affects our central vision. And so we need to do a special test for our peripheral vision. So what happens is the patient or the user is asked to focus on a target, and then lights are shone in their peripheral vision, and they're asked to click to see if they can see. And that generates a map of how sensitive their peripheral vision is. Now, visual field testing has been around for ages, and the current standard are these big machines here, and they typically require these machines. They're expensive. You need a dark and undisturbed room, and you need someone to supervise it. But you can see this is the sort of printout you get. This is a map of a normal visual field, and this is someone who's lost quite a bit of vision in the top half from one eye. And what's wrong with the current machines? They may work, but they're expensive, they're labor intensive, patients don't enjoy them, and they find them stressful, and they require people to access a clinic. Now, as you heard from Deus, there are only 4 of these machines in Burundi, and there's similar stories in many parts of the world like Burundi. While you take a place like Melbourne or Sydney, where there are hundreds of visual field machines. So they do lead to this inequality of access, and that's another issue. What's the outcome of no visual field machines? It just means that people are diagnosed much later with glaucoma. So if you waited until someone actually noticed they had a problem, someone could detect themselves that their vision was going, you've really waited far too late. We want to be picking up glaucoma much earlier than that, and hence the need for this very important test. Let's talk about glaucoma in Africa. So in Africa, there's 10,000 people with glaucoma for every 1 million population. And compared to places like the US, UK, Australia, glaucoma has a younger onset, is more aggressive, it leads to a lot more blindness, and there is a lot more need for surgery. And why is that? Well, it's a combination of very complex factors. I can't possibly cover them all in one night, but essentially a combination of genes, lack of medical and optometric infrastructure, and what Deus was talking about, a sort of a less awareness, because as Deus said, it's the sneak thief of sight. And so here in Australia, we have a fairly good awareness of glaucoma, and our optometrists know that they need to hunt for it. Patients go to the optometrist, maybe they need an update on their glasses, and the optometrist might detect early signs of glaucoma. That's the situation in Australia. But of course, you need that sort of awareness and you need the infrastructure for that. Let's put some numbers to it. This is a very good paper that came out recently from a large group looking at what stage glaucoma presents in sub-Saharan Africa. And what they found was that 58% of the glaucoma patients, when they first arrived, they had severe glaucoma. Now that's a very high percentage. I can tell you, I'm a glaucoma specialist here in Melbourne, and I see a lot of new patients with glaucoma, but they're generally quite early, and only a small proportion come at the severe stage. And also concerning is that more than half of those people, this was a population of people that went to some of the top academic centers in Africa, more than half did not perform visual field testing. And there are lots of barriers to visual field testing. One was that unfortunately their vision was so poor at the time of presentation, they couldn't do the test. But another one was lack of availability of the machines. And a final one was just not wanting to do the test. And that gets back to what I talked about before, the unpleasantness of the test and the poor user experience from the machines. So it's been a lot of fun over the last few years developing a system of online visual field testing through Ionic. And the whole premise, as I said, was replacing those machines with a software that will run on any computer. It's as simple as accessing the web browser. So all you need is a computer or a tablet and an internet access. And you can see here some examples of people doing it on different computers. And there's lots of advantages once you turn visual field testing online. You have reduced the cost, because remember, those machines have an expense. You improve the clinic flow, because often those machines, particularly in public hospitals here in Australia, become a bottleneck for patients to flow through the clinic. And so we can't see as many patients. Our productivity declines when we're reliant on those machines. Online visual field testing allows at-home monitoring, which is a big issue in the West. I think in Africa, the issue is more access to visual field testing, but home monitoring is a solution to the problems of the unsustainable healthcare budget and the increasing chronic illnesses. And there's lots of other advantages, such as integration with electronic medical records. And importantly, it's a better user experience. And I'll show you data that backs that up in a moment. But if you are converting visual field testing to an online experience, there are certain challenges that we need to consider. Computers come in different shapes and sizes. They have different white tones. So for instance, the white that you see on your computer might be more red than the white that I see on my computer, which might be more blue or darker. And then there are issues like, how do we make sure the person is at the right distance? How do we make sure they've got the correct eye closed, etc.? Because you're testing one eye at a time. These are some of the solutions that we've come up with, and I'm pleased to say we've been supported by Microsoft just to make sure that the back end, the architecture of the software is really good and up to scratch in terms of what industry expects in terms of patient experience and cybersecurity. We use a spinning fixation target. We use flickering targets to test whether the patient can see. The viewing distance adjusts based on the size of the computer, so that if someone's got a smaller computer, they're asked to sit closer to maintain the same viewing distance and visual angle. We find the blind spot, and that's another way of making sure the user is in the right position, because if the blind spot is too far to one side, it means they're sitting too far away. The app uses some AI, to be more specific, machine learning, where it engages the webcam on the computer and takes a photo of the face and makes sure the face doesn't move too far in one direction or another. Now, for computers or tablets that don't have a webcam, it'll still work without it. And it has a way of automatically calibrating in the background. So this is some of our data. You can see on the left here some example printouts from from our test compared to the standard machines, and there's quite a lot of similarity between the two. When we looked at a large cohort of patients and we looked at the diagnostic accuracy, which is a combination of sensitivity, how well it picks up disease, and specificity, which is make sure it only picks up disease and not other things, you can see our numbers are very similar to all the conventional tests of glaucoma, the OCT machine and the standard visual field machine. But bear in mind, ours is a software running on a computer, while all of these are expensive machines bought in the clinic. When we looked at the user experience, and we did this with the survey, we found that almost all of the survey items, the users preferred the Ionic online test to the standard machines. And again, it was just a more, I guess, intuitive system. People are used to looking at computers and clicking mouse in response or pressing spacebar. It's a much more user-friendly experience than putting your head in the strap and in that bowl. And then the final issue is the test stable over time? What is the test retest reliability? And you can see it's quite good that we're able to show that, do the same test on the same person over time and show little change. When we compare it directly to the conventional machines, there's a lot of agreement when we look at each zone of the visual field test that both our online Ionic test and the conventional machines are recording the same data. So let's talk about Africa some more, online visual field testing. I really believe that there's a strong role for this, and there are a lot of people, more and more, who can see this. Hardware for visual field, those big machines, they might work in Melbourne, but once you start to get to some of the remote and poorer parts of the world, they become a big issue. Even if you can get them, they are often few machines, they are often sort of hard to access in the tertiary hospitals, and they break down, and it's hard to find someone to service them. In comparison, computers, tablets, internet, these are everywhere, and they're much more easily to access, which means costs come down and accessibility goes up. And that will hopefully translate to earlier diagnosis and sight being saved and more affordable healthcare. So this is our story over the last 12 months. It's been an exciting journey, and as I said, a real team effort, a lot of wonderful people involved. In Uganda, we have been closely collaborating with Dr. Nizeyimana and Professor Arunga from the Must University, and we've just started this week to begin the trial of people performing the test on computers there in clinic. So these photos are from Uganda. I had the privilege of speaking to the South African Glaucoma Society earlier this year, presenting this and explaining this vision for Africa, and it was very strongly endorsed by the South African Glaucoma Society, and it's soon to be commercially available for optometrists and ophthalmologists via Luktor Medical. In Ghana, we've had a lot of interest, and we have now more than 20 optometrists who have signed up to the platform. And through Julie's team and Mohammed, who both of whom have done a wonderful job supporting us, talking to the important people at the Oromia district, we are talking about beginning a community trial for Ionic for glaucoma diagnosis. Again, the same sort of vision of using it for early diagnosis. So our vision is that online visual field testing leads to a wide uptake of visual field testing in Africa, because currently, unfortunately, despite the high prevalence of glaucoma, there is not enough visual field testing in Africa. We need to make sure that the distribution pathways are commercially sensible. So it's one thing for us to say, gee, this sounds like a good idea, and a very different story to actually see it happen on the ground, which will involve a lot of people, sales reps, sales company, all these parties are incredibly important to this story, and we need to make sure that everyone is aligned and everyone is sufficiently motivated to make this happen. And I firmly believe we can do that. This will all lead to glaucoma being diagnosed at an earlier stage, and sight will hopefully be preserved for many people. And hopefully one day glaucoma will become a preventable disease in Africa. Thank you.
Thank you so much, Simon. Now, last but not least, Dr. Geoff Cohn OAM, and he has a lot of qualifications. Honestly, I don't know. I will give you have a minute to introduce those qualifications, Geoff, but okay. So I'll continue introducing you. He is a developer of blindness remediation projects for Republic of Botswana. Is that Botswana? And Navjin Hospital, Bihar, India. Rotary Bali Blindness Project, now the John Fawcett Foundation. Papua New Guinea, Cambodia, Eye Care Project. Myanmar, Eye Care Project. Andhra Pradesh, Eye Care Project, India, and Tipitaka, Kakao, Ala, Jivitadanus, Sagano Eye Hospital, Myanmar, and 2004 to 2013, Chairman Overseas Aid Interest Group, Royal Australia and New Zealand College of Ophthalmologists, and 2019 to 2020, Honorary Consultant, Australia Ethiopia Eye Care Project. Now he will present his talk entitled Affordable Procurement of Quality Equipment and Disposability. Now it's time for you, Geoff.
Thank you very much, Jonas, and thanks for the invitation. I think having my email address is going to be of more value to people than anything I say, because 100 years of experience has taught me a lot. We need different equipment in screening outpatients, outreach, minor procedures, major procedures, but it's possible to do this anywhere. For example, these Cambodian volunteers coming from the villages have $12 loops, which are very effective. They love the inbuilt lights, but we give them $3 LED torches. They can screen. They can do a great job of finding the problems. And you really need them when your end of the day number of patients waiting looks like this. We can screen anywhere, and we need to get to the people, as my colleagues have pointed out. If you happen to come across a young child, this 6-month-old had congenital glaucoma, the average Australian ophthalmologist would be appalled to see me doing glaucoma surgery under ketamine with people holding the child down. Now, there's no pain, but that's the choice we had. Do nothing or rescue her eyes, and she's doing well. Compromise is necessary, but we must always question it. What's been terribly important for us, especially in Myanmar or Burma, if you prefer, is finding powerful allies. Pusin Mon, who's with me around the post, is one of those extraordinary people who solves problems while others are creating them. And the very powerful Chief Abbot next to me supports us in a way that lets us work despite the military. Terribly important. The world has changed dramatically with India and China particularly coming online. Your expensive operating microscope in Australia, the West, Europe, can become a perfectly adequate Chinese operating microscope with good coaxial light, but it's not going to last forever. If you want something that's really durable, and I can give you many specifics, you'd want to look at Scan Optics from South Australia, who make absolutely amazing operating microscopes at a very good price. The ones I delivered 30 years ago in Papua New Guinea and Cambodia, well, that was 23 years ago, are still going strong. Slit lamps from India and China, a fraction of what is paid in the West. A scanners, China, superb. Are they ideal? No, but we've got to look at adequacy. We can't afford to be choosy. The lens implants in Myanmar 3 months ago, we were paying $2.80 per, I'm speaking US dollars, for a rigid lens, and about $20 for a good foldable implant. These are Indian made. And you can see that the pricing of dexamethasone, ciprofloxacin, etc., is dramatically lower. One needs to know who the good and reliable manufacturers are. It's not a universal truth, and we have a lot of contacts in India who advise us. Biometry, people throw away equipment in a country like Australia, and our junk is a treasure when it makes its way to a country that needs it. Keratometers, people don't want here. Chinese A scanners, pretty inexpensive. We'd all love to have the Zeiss IOL master, but get real. Not only do we want to acquire the equipment, but we want to ensure it is not a paperweight. We need maintenance, a terribly important skill. And there's a remarkably generous fellow who helps me with that, who has at no cost other than his transport flown to Cambodia and Myanmar to teach maintenance so that we don't have expensive paperweights that look like YAG lasers and slit lamps. Plan for viability, folks. If you don't have suitable storage conditions, you're in trouble. High temperatures, light, etc., will destroy your valuables. They will not survive. We need to look towards serviceable equipment and not be distracted by fancy equipment. Serviceable means a slit lamp made 100 years ago might be working, and it's a lot better than a torch and the naked eye. These are the Scanoptics basic microscopes. Those didn't even have foot pedals. They're a lot better now. And remember your uninterruptible power supplies, your batteries. The Scanoptics microscopes even now can work attached to a car battery if the power fails. It does fail. In respect of glaucoma, we'd love to have tonometry done everywhere, but when you see this tragically, totally blind gentleman, be grateful that his children brought him, because you can examine them and you're probably going to find, it being East Asia, that they have angle closure glaucoma. I would argue that we need not just tonometry, but also pachymetry, especially in Africa, because it's a key point. And in East Asia, angle closure rules. We need to do gonioscopy. Yes, it takes time, but in a recent study, I saw 350 pairs of eyes in a day to do gonioscopy in Myanmar. If you're able to buy local, buy local. We bought some microsurgical instruments in Papua New Guinea, as you can see, and used them to mimic pterygium surgery. Linen made locally, laundered by the locals. Appropriate technology, both that horse cart, pony cart, and the YAG laser are appropriate technology. Put them in context and you won't go wrong. Yes, the YAG laser costs a lot more, but there are ways around that. I argue that we should train people to do refraction the old-fashioned way, because autorefractors break down. People don't. They do a wonderful job. Where do we operate? Well, those are dining room tables and an obstetric bed. Not one of those places had electricity But they did have trachoma, they did have pterygium. So off for the dining room materials and on goes the patient. Borrow if you can. If you're in a country with other that has other projects working, see if you can share. You may not like what they're offering, but you may have trouble giving it back, as you can see, but share where you can. You may find the instruments difficult to get used to, but share, borrow, beg. Learn from the locals, but don't be overwhelmed by local fetishes. Indonesia, when I first went there, didn't want to use microscopes. We've had such problems in many places. I'd love to be able to share this philanthropist with you, but we had to go to Las Vegas, my son and I, to sing karaoke with him in order to get donations, and I can't share him. So we have access to the equipment. It's easy enough to teach the people. We do need some funding, but a very modest amount of funding. It's not that much. Please feel free to use my email. I'm pretty quick on the return and happy to offer advice. Thank you, Jonas.
Thank you so much, Geoff. In the interest of time, we have time for Q&A, but let me read the appreciations and feedbacks from the chat box. So to the first presenter, Julie, of course, you cannot save the world, but you saved the world of your patients. Kudos to you, Julie. And the other comment is just inspirational. Then we have one question to, it looks question. Yeah, the Schultz tonometer is inexpensive and durable. Do Deus and Simon regard it as acceptable? This is a question.
Can I answer this question straight, Jonas?
Yeah, go ahead, please.
So as you may know, Schultz, these are old devices that are not, as I said, people are more reluctant to put something in their eyes. And Schultz tonometer have been found very uncomfortable, even for professionals who are examining a patient. Even the Goldman tonometer, sometimes they don't accept and they prefer other devices. So it's the lack of awareness because, you know, it's they still have other issues. So many people, they don't prefer. If you want to use that, they say, no, don't put that in my eye.
All right, thank you so much for this quick answer. Then I get one question to Simon. Online visual field sounds like an amazing breakthrough that represents potentially limitless possibilities and benefits, especially for Africa. So that's not question, but appreciation. I am Dr. Niteka, a GP, working with refugees in Uganda. The eye health of refugees is really concerning and neglected as humanitarian agencies have other priorities. However, in outreach conducted in one of the refugee camp, 10 out of 70 people screened had glaucoma, 4 had cataract, and other ophthalmologic conditions. How would you help to address eye conditions among refugees? Who is going to take this question?
That's a very tough question. That's a very tough question.
This question is
I think
coming
we are
from
all
Africa.
concerned. I think we are all concerned. So it's a very important question because this data is higher than what we used to have. So it's very difficult to address that at this time, but I think I'm in contact with Dr. Dora in Uganda. Maybe we can organize another time to talk about how exactly we can link her with Honorine, who is in Uganda, and the other colleagues that are there, because the way probably this has been conducted, we don't have enough information to talk about, to give an answer. But if there is anyone who can respond to that question, yeah, that would be good. Geoff?
Yeah.
I'm dealing with exactly this problem, Jonas. There are more than 1 million new refugees from Myanmar in Thailand. I went to Chiang Mai a few months back to meet up with some of my teams from Myanmar, because they can come out. Not the doctors, but the auxiliaries can leave the country temporarily. And we're trying to set something up in Mae Sot, just across the border in Thailand. All we need is a room. I have spent about $5,000 US, and that will equip a basic clinic, including a tonometer. I've been given an autorefractor. I will pay the first year's salary for 2 trainees, one within the refugee camp and one within the displaced persons camp. My problem at the moment is finding a venue, because there are many rooms there. There are many NGOs there, and nobody is offering a room. But we'll find that. And we'll train auxiliaries as a starting point. We do have Thai ophthalmology contacts.
Thank you, Geoff. And there is one, it looks comment, and thanks for sharing your experience, Dora. It must be extremely difficult, if not impossible, for the already vulnerable refugees to find help.
Yes, if I could say something, I mean, these are great comments. I think the challenges are there, but I think if there's, I guess, one message that we want to get out is that you can see the 4 speakers, we have all a different approach. We see the problems and we come to them from different angles. And I think the idea is that we need all of these approaches. You know, we need to think about, as well as delivering eye care, but not just delivering the same sort of eye care that we do in places like Australia. We need to be adaptable. And as Daya said, we need to make sure that it's a user-friendly experience. We can't just do things that people don't like, because there's a problem of awareness. And also we need to think about new technologies and how we can use them to our advantage.
All right. Thank you so much, Simon. So now it's time for additional questions from the audience. Please feel free to use under reactions. There is, you can raise your hands like this one. Is it visible? Please raise your hands. And I'm not trying to be an old school person, but just for us to speak turn by turn. So raise your hands and come, raise your questions, comments, appreciations.
Yeah, I think Christian has a question. Yeah.
Oh, hey, everyone. I just have a question, and I just want to thank everyone. I think your presentation was just amazing, especially Julie and Simon. Simon, just because I think his research is very promising, especially for those places where those very expensive diagnostic tools can be almost inaccessible. So what's your plan, Simon, for making your new approaches to addressing these problems, costs, I think based problems of early detection of glaucoma? So how are you planning to make even, because you mentioned that you have studied some clinical trials and they are promising. So what's your plan to making research approaches, even a result available to all the clinicians, especially in those poor areas where can really save people?
Yeah, thank you. It's a really good question, and I certainly think a lot about about the answer. I think, as I said earlier, there's a big difference between a promising idea and a reality on the ground, and distribution channels are the key. And it's not easy, and a multi-pronged approach is important. As I said, it has to be commercially viable, because without that, it won't work. It won't get very far. So we need people involved in promoting and distributing, explaining the why, and I think, and that comes down to what Deus was talking about, is simply raising awareness for glaucoma. And obviously there are other issues, problems people have to grab their attention. Glaucoma isn't like that. It sneaks up on people. So we need to create the awareness, and also about the culture of visual field testing. And this is something that I've learned over the last few years, that if there hasn't been visual field testing in many parts of the world, there isn't a culture of it. Even the clinicians aren't quite aware of what and how it's done, and what its use is. So I think that is important as well. And organizations like the World Glaucoma Association, which is all about that sort of integration and transfer of knowledge, is again so important.
Yeah, I don't know if I can follow up and just raise my concern. Pretty much all the presenters just spoke about working with different organizations in different countries. Don't you find it a bit concerning that, or maybe let me ask a question. Do you have any partnership with any African government, for example? Are they involved in promoting this kind of research? Because I'm just talking from my own personal experience, because we have noticed, I myself was once a medical student in Africa, and really having like a broken health system, and where the government pretty much they are somehow irresponsible. So are the governments in Africa or in different those developing countries really supporting this initiative? I mean, for example, Simon's approaches to finding new diagnostic tools that are quite cost effective.
Yeah, Christian Duimana, can I just ask you one question? We would like to know where you are based.
Me?
Yeah.
I think that's relevant to my question.
No, I will reply, because based on where you are based, if you are, for example, in Australia, my response will be different. So I will answer to that question, because I've been working. I worked in Nigeria when I was trained, and I worked in Burundi for about 2 years. Our health system are even not a part of the general system in many countries. And if you go back, for example, in Burundi, there is a department that we call the MTN, the Maladie Tropicale Négligée, if you understand the French, which is the department for neglected disease. So it was just offering services for onchocercosis, and there was nothing for glaucoma. But this year, with the support from Fred Holz Foundation, which is an Australian organization, they have funded. They have worked on they put in place a strategic plan, a 5 years strategic plan to prevent blindness, and they want now to set some primary eye care in every hospital, district hospital, or dispensary in Burundi, where they will have a small unit for eye care. Because it's even if it's a small country where you have to travel 1 day just to check your eye, it's very concerning. So there are a lot of work that have been done. And the Burundi Glaucoma Association, we use the patient because they have a voice and they have a contact. So if you can see in my talk, the Ministry of Health have been invited in 2 meetings organized by patients and ophthalmologists. Of course, there may be some challenge, but it's good to start. and they start talking. That's a kind of lobbying and advocacy. And also, we have conducted a kind of awareness that was intended to the senior staff of the health ministry in 2021.
So thank you so much, Deus. The reason why I asked that question to Simon, I went to a conference organized by a Kenyan researcher, a professor from Kenya. He was talking about lack of support, like for new innovation, innovative ideas. So that's why I was asking Simon, specifically asked Simon to answer me if there is any partnership with any government in Africa or anywhere else supporting that idea, because I think it's promising. So that was my question, just to Simon. I'm not saying that.
No, I can answer it. The answer is yes. As I mentioned, through Julie and her team, we've had a number of talks with the Oromia health district officials. So basically getting quite high up there in the health department of Ethiopia, and that's just a start. We have ambitious plans, and as well as government, it's important, like getting the endorsement of the South African Glaucoma Society, for instance, because that is so important. I mean, I haven't told you the whole story of what's happening in South Africa, but you can see that one thing follows the next, and I think everyone's talk, I think Julie's and Geoff's talked about engaging with government, and I agree with you. It's incredibly important. You can't avoid it to make a success. Jonas, there was a comment from Fred, which I think we should discuss. It's a really good comment about social media, churches, and influential athletes to raise awareness.
Yes.
Fred, yeah.
Thanks for organizing this webinar. Very informative question. Can you capitalize on the social media, churches, and the many influential athletes to assist with raising awareness? Yeah, so there's also another question. Shall we do answer turn by turn?
Well, I mean, I just want to say how important social media is, and I think we as doctors are sometimes a little bit scared of social media and sort of new ways of communicating and influencing, but that's important, and I think we need to become literate in social media and use that to our advantage to promote good health promotion messages.
Yeah, there are also other ways like local community radios and stuff like that can be used to raise awareness. I know social media is these days viral, and there are yes, it can be reached, but other ways that we can raise awareness through.
And I think you Jonas and Deus have been good examples of that. We, for this webinar, for instance, we've had interviews with journalists in many different languages that are appropriate for Africa. So doing it in a smart and culturally sensitive way is a good idea.
Great, thanks. There is also one, I think it's comment. The Buddhist monks in Myanmar offer invaluable support, as does the Church, Medical Council of Papua New Guinea. Our Cambodia project has a good, long-standing memorandum of understanding with central and provincial government. That's from Geoff, and yeah. All right. I have one question for Julie. Ethiopia is the over 100. Not, I am cautious of the number because recently the government has issued about the population of Ethiopia. But anyways, Ethiopia is over 100 million people, and you are intervening in Mekki and Shashamane area. And there are about 1 million blind people, and it looks that the intervention is really important, and we don't have time to respond to the problem on the ground. But is there any way other than you have a vision to expand it to other African countries as well? I think if I understood it well from your the last second slide. So what is your strategy to catch up with the vast problem there?
The strategy is to chip away at it bit by bit. It's a very small organisation, all volunteers, everyone has their own busy lives, and it's taken a long time to get Eyes for Africa to have been respected in the country for what we're doing. Now we can just tick along, and with the support that I have, I can't see that I need to go to any other African country when there's so much work to be done where we go.
Mm-hmm.
I don't have many stumbling blocks now. It's just affordable, and it runs really well when we get there.
Well, thank you so much. And there are other comments and questions, and I'm concerned by a young student who became blind consecutively to malaria overdose. We don't know if he had glaucoma or not. Unfortunately, many other victims are known in Burundi, and they don't receive any assistance. There's also a continued comment on how can you help these young blind people? I think this is to Deus.
I think I prefer first, because I know this case. So I was just going to ask my other Simon and Geoff if they have came across other similar cases, because myself, I had, I think, 2 cases of people who had malaria. So they were taking the treatment, and at the end, they have a bilateral blindness. So the question he has raised, I know him very well. He's a younger guy who is around 20 years old, but he became blind. The question he's asking is, how can we help blind people? Because in Burundi, we don't have a service of low vision. We don't have data services. He's asking, how can we help them? Is there anyone among the speakers who can help answer this question?
I think Julie showed us that terrific slide of that great young man that brought canes, and sometimes we as ophthalmologists we're focused on fixing. We love to fix, and we need to acknowledge that there are things we can't fix, and that's when the low vision services are so important. So as you've done a great job setting up the Glaucoma Association in Burundi, that there are other associations that hopefully could be set up one day.
Julie? Geoff?
May I? There's some years ago, I spoke to Vision Australia in Melbourne, who offered to cooperate with the team in Myanmar to set up blindness services. At the time, we didn't have any way around the government, and that didn't happen. But speak to Vision Australia in Melbourne. They were superbly helpful, and I'm sure they'll help you. May I add, somebody asked, has anyone tapped into Rotary and Lions? Yes, both. And they can be very helpful, except sometimes I'm promised that if I go somewhere to give a talk, I'll get a lot of money for the project, and nothing comes. Gets a bit tedious, especially when I've traveled halfway across the continent. But one must always try. I'd like to add one more. We found in Indonesia that the central government was not part of the solution, it was part of the problem. However, the provincial governors and provincial health departments were totally different. We could work with them, and they were really keen to help. We tried a number of other avenues, and the Navy proved to be the Indonesian Navy, very happy to move our mobile operating theaters from Lombok to Flores and on. So try every avenue, because sure, the Navy wants to take videos of everything we do and take credit for it. They're welcome to it. They're helping us. We don't care.
Thank you so much, Geoff.
I think, Jonas, there is something that I would like to add. We have Dr. Honorin, who is currently doing some research using ionic technology in Uganda. She used to undertake a low vision training in Uganda in 2017. Honorin, I think there is a plan to set up in Burundi a low vision service, and this is a part of the current 5 years strategic plan that is being supported by Fred Hollows Foundation. So it's really, yes, we can help in terms of raising awareness of that and trying to convince effectively those who are making a decision to put that in the program. So the problem there is a good initiative, but getting funding that is really, really challenging in a country where there are a lot of challenges.
Thank you so much. If you have any final words.
There is one question, Jonas, that I have to raise from Christian.
Okay, what was it?
How is the
raised a good point on that?
There was a question. They used to raise a good point. How is the glaucoma trying to rise this way?
Yeah, doing a few things upstairs.
Yeah. So as we said, the good thing that we have, in the organization, we have patients, we have ophthalmologists, we have the people who are able effectively to get connection through the administration, because the hassle that we have when we wanted to make a change, especially in our country in Africa, it's knowing the right person, because you need to go with a plan, but sometimes it can be delayed. But I think with ophthalmologists and the patient, and also we involve local media. So we've done a kind of debate between one patient and an ophthalmologist at the national television. We have already conducted an awareness program to the Ministry of Health. We want also to extend that, but as we said, it's moro for those who understand the Kiswahili. It's just a moro. It's slow, but we are confident that at some point we will be able to get the things done. The other thing that we did is we were able to push so that glaucoma be included in the national strategic plan, which is a good thing, because in the past there were nothing where they were planning to do something for glaucoma. But getting that done, even someone who will have a project or funding, they will be able to run any project, because this is a part of the national strategic plan. It will be much easier than before.
All right. Thank you so much. Today is World Sight Day, which was initiated 23 years ago by International Lions Club. And this year's motto is "Love Your Eyes at Work." So I would like to thank all the practitioners on the ground, boots on the ground, Julie. They with the simplified and making the testing and monitoring accessible, affordable, and usable. Simon, and Deus, who has presented to us lived experience initiated or lived experience led response to glaucoma, which is very important because of the synergy of expertise by both living the life of a patient and by having the knowledge in the field. And finally, the affordable procurement by Geoff. That's really amazing. So how we can make our, in this expensive world, in this where the cost of living is soaring, and where we are facing the challenges, then this is a very good combination of presentation. I'm really proud to be your master of ceremony. I would like to ask the audiences to drop in one word this: how has your experience been with us in the last 1 hour and 30 minutes? Please just drop it in one word, how you felt about the presentation and the question, answer, and discussion. So with that, I am going to finish. I give you 3 minutes to drop your feedback for us so that we do better and come back with the agenda that have been chosen by you. Thank you so much.
Thank you, Jonas.
Yeah, Jonas, we should say also that we will be posting this on, uploading this to YouTube, and that there will be a link to the video through YouTube that people can access of the recording.
Yeah, thank you so much. I think the remaining 14 people, 19 people, 16 people will be aware of with this message.
Yeah, there are people who are requesting for another session. I think we can, yeah. Why not?
Yes.
There's too much to talk about. I think we can, yeah, keep that conversation in future. Okay, thank you. You've given us hope for better eye health in Africa. Good.
Yeah.
Yeah.
The Australian Air Force and the Navy have been remarkably helpful. Okay. Yeah. Yeah, I asked them in one word and
there's too much to say.
yeah.
You can pick up and balance.
Yes.
Yeah, just
yep. Good.
Okay.
Thank you so much.
Thank you, Jonas.